Okay, okay.
I do.
All right. And it's like, okay, I'm aware of it, I'm aware of it, I'm aware of it, I'm aware of it. Is it ever going to stop? Blah, blah, blah. Pain, can you imagine why we might always be alerted to pain?
So we can stop.
So we can stop. The body wants that tissue to heal. But in a lot of cases, what do we do if we feel some pain? Do what?
Ignore it. Don't take notes.
Or take something. We'll take a Tylenol or an Aleve or something. Sometimes, yeah, we have to, because it's just like to the point where I just, okay, I'm just tired of feeling this pain. But in reality, pain is alerting the brain that something is wrong with the tissue, and it wants the tissue to heal. And the way that the body goes about dealing with pain, depending upon the situation, it can be rather interesting. Because you can have the severe, the extreme, or you can have the one that's just slowly sending these signals 24/7. The other type that's really good to mention, proprioceptors. Do you remember these? Or where we said they might be located? Where did we find them in the body?
Like the muscles of the tendons.
Yes. We're going to find them located, like in that muscle or tendon, at the joints of the body. And what happens, they help to send information about our place in space. So what do you think is going to have that information is going to have a big effect upon?
Can you say that again?
Our place in space, standing, sitting, twirling, whatever the case might be, what of our special senses do you think needs to have the majority of that information? Our equilibrium. So, gets a little bit interesting with these special senses. When we talk about the receptors, we tend to classify them. We can classify them based on their modality. What is their mode of delivery? Origin, where are they located? And where do we distribute them, or where are they distributed in the body? By mode, by modality, we can have thermoreceptors, which means they're checking on what?
Temperature.
Temperature. All right. How about a photoreceptor? Sight. How about nociceptor? Ever heard of those?
So, what pain?
Pain. Nociceptors are for pain. What about a chemoreceptor?
Radiation.
That's what kind of comes to mind because we associate treatment of cancer with chemo. But chemical. Wait a minute. What? What are chemicals? What chemicals? What's going into my body, chemical-wise?
Whatever's in the air.
Alcohol.
Food ingested.
Food,
Alcohol.
alcohol, stuff that we smell is chemical-based. Yeah, it's really interesting. And then a mechanoreceptor. mechanics,
So like muscle movement.
movement, which of course is going to play a part with our proprioceptors. If it's an exteroceptor, where do you think that receptor is located? On the outside. If it is an interoceptor, internal. And then, of course, lovely proprioceptors. In the body, we can have them distributed throughout the body in our general senses. In our special senses, we're going to tend to find only one type is present. For example, if we look at the eyes, they're going to be worried about light. So they're going to be photoreceptors. General senses overall had very simple receptors. They were either termed to be encapsulated or unencapsulated, stuff such as a free nerve ending. They help with information about the warm, cold, pain. A tactile disc, they're tonic, meaning they would send a little bit of a constant response. Hair receptors, believe it or not, unencapsulated. And luckily, the way that those work, we're not aware of hair. I mean, if we had to be aware of every single hair on our head, we would go crazy. That's just point blank. Encapsulated means they had some tissue wrapping. Tactile, which would be phasic, like light touch, texture. We had end bulbs, some of those for mucous membranes. Bulbous, once again, tonic, but these were for more heavy touch, stretching, and so forth. Lamellar, phasic, but those helped with vibration, but those are going to become important with our proprioceptors, because that's going to help us with, say for example, riding in an elevator, riding a roller coaster, okay? Because the goal, when you get off of that type of stuff, is that you're still standing upright, all right? And that no other parts of the body are trying to show. You know what I mean? Like, I don't know. Okay. So, what we're going to find is, up to this point, we have learned that for a general sense, that meant soma, our projection pathways were, in all sense, in all understanding, for general senses, easy. Okay? The projection pathway, we tend to have our receptor. We would get the information to the spinal cord, take it to the thalamus, send it to the region of the brain that it needed to go. Because what's another term for the thalamus?
Relay.
The relay center. Now, anytime we have information that goes to the central nervous system, we're going to say that the information going to the area is a projection pathway. For the most part, information that has to go travels by 3 neurons. The first, second, and third order. That can be a little different now. Some of the information travels directly by the spinal cord. Some can actually go by way of the cranial nerves. For example, proprioception. Proprioception is going to go to the cerebrum first. Do you happen to remember why?
You said it again.
To the to, I'm sorry, the cerebellum. Do you happen to remember why? What is the cerebellum? What does that play a huge part in?
Like movement and locomotion.
Our movement and our locomotion. So it's going to go there before we reach equilibrium. So it'll have to go there to get to the part of the ear that's going to deal with the equilibrium. Now, once again, pain. And there's a reason that we kind of bring this up, okay? Like I mentioned, it's necessary, all right? It is tonic, meaning it stays with us, okay? The body until the tissues that are damaged are healed. We will constantly get that information about the pain. Like we said before, the nociceptors are those receptors for it. We find that nociceptors are very dense in the skin and our mucous membranes. We have nociceptors on almost all of our organs, but not the brain or the liver. This is why once they start brain, like if you have to have any type of surgery on your brain, once they've, cut the skull and everything, they can wake you back up. All right? They have to. Because doing anything to the brain, you got to make sure they're not going to hit a part or something that they shouldn't be hitting. Okay? But you don't feel any pain because there are no receptors for it. Now, what will happen? Fast pain. Yeah, that happens first. When you first do the injury or the damage to the tissue, for the most part, you feel it quickly. Cartilage is a little different because cartilage doesn't have the blood supply and the innervation. Okay, so when you damage cartilage, it usually takes a while for you to feel it because it actually has to create the damage to the tissues around it first. Okay, the slow pain can kick in. That's that dull ache that we tend to have to deal with. Might take the Tylenol, leave, whatever the case might be. Now, not only do we have somatic pain through the body, our viscera can hurt, our organs. But the question is, how do we know? How are we going to know when our viscera hurt? We're going to have to receive that information. Just like we would, like if we picked up this paper and got a little paper cut, okay? And your first instinct is, now. And then you're like, oh, okay. You're done. All right? So the way that pain is going to work for this stuff out here, for the body, okay? We're going to send it to post-central gyrus. I'm sure you guys remember that gyri that we mentioned. Now, in somatic pain, they're kind of showing the pathway. Visceral pain has to be dealt with differently. Visceral pain has to go into the lateral sulcus. Do you remember when we had the brain open and we're looking at the two halves and we pointed out that one lateral sulcus that was present? Okay. Then, once it gets there, the information has to make a part of the body hurt. For example,